I would like first to present myself. I am Professor Hosam Hasan Arabi. I am the head of cardiovascular medicine department in Asyut University and director of Asyut University Heart Hospital. I would like to present today an important issue nowadays, which is RAS blockers and COVID-19 speculations versus facts. Coronaviruses can cause respiratory and intestinal infections in animals and humans. It was not considered to be highly pathogenic to humans until 2003 with outbreaks of SARS, severe acute respiratory syndromes in China. Before 2019, 6 human infecting types of coronaviruses were discovered, 2 highly pathogenic, which were SARS coronavirus and Middle East respiratory syndrome coronavirus that cause severe respiratory syndromes in humans. The other 4 human coronaviruses you see induce only mild upper respiratory tract diseases in immunocompetent hosts. In 2019, a novel coronavirus, which is called SARS coronavirus 2, was identified in China and is named by the WHO as COVID-19, coronavirus disease 2. First, we will discuss angiotensin converting enzyme and angiotensin converting enzyme 2 axes and their interaction. The RAS system, you know all, has a critical role in normal cardiovascular functions and contribute to a spectrum of diseases like hypertension, coronary artery disease, myocarditis, and congestive heart failure. It starts with angiotensinogen secreted by the liver that is acted upon by renin that is excreted by the kidney under hypoperfusion conditions, converting it into angiotensin 1. Angiotensin 1 is converted via angiotensin converting enzyme that's excreted mainly by the lungs and in addition by other tissues to angiotensin 2. Angiotensin 2 has a spectrum of effects that cause salt and water retention via sympathetic activity increase, sodium and water retention via the adrenal cortex, suprarenal gland increase aldosterone secretion that causes further salt and water retention, and vasoconstriction directly and via aldosterone secretion, and on the pituitary gland causing antidiuretic hormone secretion. This RAS system have an additional pathway that's called angiotensin converting enzyme 2 pathway. When angiotensin converting enzyme 2 acts on angiotensin 1, that's also called angiotensin 1 to 10, converting it to angiotensin 1 to 9, that's converted by angiotensin converting enzyme into angiotensin 1 to 7. Another pathway for generation of angiotensin 1 to 7, which is the main pathway, is a conversion of angiotensin 2, that's also called angiotensin 1 to 8, into angiotensin 1 to 7. Angiotensin 1 to 7 has that's the opposite actions of angiotensin 81 receptors acted upon by angiotensin 2. It causes vasodilatation, anti-hypertrophic, antioxidant, and anti-inflammatory and anti-fibrotic effects to the lungs and the cardiovascular system. ACE2 is a natural damping mechanism for the activation of the classical RAS system. In the living body, ACE, angiotensin 2, 81 receptor axis, and ACE2, angiotensin 1 to 7 MAS receptor axis balance each other. Angiotensin converting enzyme, angiotensin 1 to 7, and the MAS receptor axis has cardiovascular protective, vasodilator, anti-inflammatory, anti-proliferative, anti-fibrotic, anti-alveolar epithelial, apoptotic, and antioxidant stress effects, as I said. How came the basis of the link between COVID-19 and RAS inhibitors? This came from the paper published in the Lancet Respiratory Medicine on March 11 as a letter by Fang et al. That hypothesizes that patients with diabetes, hypertension, or heart disease treated with ACE inhibitors or ARBs, which are suggested to be angiotensin converting enzyme 2 stimulating drugs, are at increased risk of developing severe and fatal COVID-19 and should be monitored for these drugs. The speculation came from the observation that hypertension occurs in 15 to 30% of patients with COVID-19 and up to 15% of coronary heart disease patients. When you look to this table, it shows that patients requiring admission to ICU have a prevalence of hypertension of 58% compared to 21 to those of non-ICU patients, and in diabetes 22% in ICU patients compared to 6% only in non-ICU patients. So probably the disease itself or drugs used for treatment of these diseases would be the cause. The observation also came from the old data from animal studies showing that ACE and ARBs were shown to exhibit ability to upregulate ACE2 expression in several animal studies. As you see here, losartan, olmesartan, lisinopril, losartan in different trials. When you understand the cell entry of coronaviruses together with the previous data, the coronaviruses has a spike S protein called S protein on the surface, causing its corona shape. This S protein is attached to a receptor in the lung cells called the ACE2 receptor. This ACE2 receptors require a proteolytic enzyme for priming or cleavage of the S protein called transmembrane protease serine 2 enzyme that causes priming of the protein. So membrane fusion will occur of the virus with the cell, causing the single strand RNA of the virus to go into the cell and become incorporated into the nucleus of the cell, causing. So the higher the ACE2 level, the higher the viral load that the cells will be exposed to, and this causes downregulation of the ACE2 in the body, causing the axis of ACE2, angiotensin 127 and MES receptors to be decreased, leaving the axis of ACE81 receptors unopposed, causing increase the prevalence of the occurrence of ARDS in these patients. From this came the concept of vaccination or treatment of coronavirus. There are four means for antagonizing the therapeutic approaches for the virus. The first is by development of a spike 1 subunit protein based vaccine that's given to the cell to inhibit the protein, the S protein. The second way is the inhibition of the transmembrane protease serine activity. The third means is by blocking the ACE2 receptors by ACE2 receptor blockers. And the fourth means is by delivering excessive soluble forms of ACE2, human ACE2, recombinant human ACE2 that's given to the cells to antagonize the viral infection. Cooper et al. Provided a genetic proof that ACE2 is a crucial SARS coronavirus receptor in vivo and SARS coronavirus infections, and the spike protein of SARS coronavirus reduce ACE2 expression. On the other hand, this study also found that blocking of RAS pathway can attenuate the worsened acute lung failure induced by the injection of SARS coronavirus spike protein in mice. This is an opposite thing. Against this concept, after this paper, several papers were published. This paper was published in March 22, saying that it is a speculation, not an evidence. This was based on several data. Some are old data. Not all data from the animal studies showed that ACE inhibitors increase ACE2. Ramipril, for example, failed in this study to increase. This table, for example, shows us the angiotensin receptor blockers studies. When you look to the table, you will find that most of the studies are animal studies with very few human studies that showed no increase in ACE2. And even in animal studies, the increase in ACE2 was not uniform in all studies, despite being present in most of these studies. The same applies for the animal studies for angiotensin converting enzyme inhibitors. Not all of them increase ACE2, but most of them, and we are lacking human studies that confirm this. There has not been any good evidence of ACE2 upregulation associated with these drugs in human, and despite 61% sequence similarity between ACE1 and ACE2, ACE inhibitors do not affect ACE2 receptors. Why? Because animal studies are predominantly based on tissue expression, and human work was based on soluble circulating ACE2, because it is impossible to take samples from tissues to study the tissue expression of ACE2. The relationship between both tissue expression and soluble circulating ACE2 is not clear yet. This is an important article published by Task Force Review of Evidence of the European Society of Hypertension. It shows that when you look to the evidence available till now for the effect of RAS blockers on tissue human ACE, there is no evidence till now for the oropharyngeal effect on ACE2. There is no evidence of RAS system effect on human ACE2 in the lungs. The evidence is present only in the GIT. On the opposite hand, the portal of entry of SARS-CoV-19 was confirmed to occur in the two sites that's not confirmed to show increase in ACE2 by RAS blockers, the oropharyngeal route and the lung route, while the gastrointestinal route it's not confirmed to be a route for entry till now, and the SARS coronavirus has not been detected yet in urine. This slide shows to us what we said about the unopposed effect of AT1 receptors by downregulation of the axis of ACE2 angiotensin 1 to 7, causing the reduced beneficial effects of this axis, leaving the unopposed effect of AT1 receptor axis. The same is explained here in this, and this is applied for the old SARS coronavirus and the new SARS coronavirus. This article, it's an old article for the old SARS that shows that angiotensin converting enzyme 2 and angiotensin 127 mass axis serve as a novel therapeutic target for the treatment of lung fibrosis and pulmonary hypertension. And this is very interesting, opposite to what was said by the speculation. This is another paper in the old SARS systematic review and meta-analysis of the papers on the old SARS, showing that the best evidence available towards putative protective role of ACE inhibitor, but there was no role for ARBs in this meta-analysis. Patients population that may benefit are those mainly with previous stroke and the Asian population with associated decreased pneumonia-related mortality, but the data are lacking. In this, you will find here the odds ratio is 0.66, so you have 34% relative risk reduction with ACE compared to non-ACE therapy, and was not present here with ARBs, and was significantly different between ACE and ARBs. On the opposite hand, there is a new paper showed that ARBs are actually beneficial. Without ARBs, there is no protection against increased effects of angiotensin 2 AT1 axis and increased probability of occurrence of inflammation and fibrosis ARDS in infected patients with coronavirus. On the opposite hand, with ARBs, there is a protection against increased effect of angiotensin 1 AT1 axis, and ARBs is attenuated. This is another speculation against the other speculation. In addition, in this article, we have another speculation saying that ARBs, as you see here, stabilize ACE2 with AT1 receptor together, reducing the availability of SARS coronavirus 2 entry while reducing endosteroid excess. So this is another way AT1 ARBs can be beneficial in these patients. In conclusion, for this presentation, the risk of coronavirus or influenza virus infection is high among the cardiovascular disease suspected population. A suggested explanation is at least partly due to high ACE2 expression in this population, which needs to be confirmed in the future. There is no evidence that the possibility of harmful effect of ACE inhibitors and ARBs is more than a mere speculation, despite being enormously amplified by both the conventional and social media, forcing the major international societies to issue position statements though with different intensity. If real, the overexpression of ACE2 might be protective for lung by opposing the devastating effects of angiotensin II. For infected patients, although higher ACE2 expression might be associated with a higher viral loads, ACE or ARBs should not be discontinued assertively because they can block the RAS and protect patients from potential heart injuries in COVID-19 and might also reduce the severity of lung damage caused by infection. This is a speculation. On the other hand, there is no immediate need to initiate ACE or ARBs because there has no definite evidence that they benefit COVID-19 patient survival. These are speculations against. In contrast, low blood pressure values and blood pressure drops within the first 24 hours after hospital admission, as recently shown for COVID-associated pneumonia, may represent risk factors for adverse outcomes in COVID-19. This clearly highlights the need to closely monitor severely ill COVID-19 patients with hemodynamic instability and to withhold and adopt blood pressure lowering therapies according to guidelines. So the decision here is based on guidelines, not on the COVID-19 risk or benefit. COVID-19 patients with hypotension and particularly critically ill patients are highly susceptible to acute kidney injury, and this should be kept in. The European Society of Cardiology Council on Hypertension and the Heart Failure Society of America, together with EgSC and AHA, made position statements, very important statements, saying that it's crucially not to draw hasty conclusions from simple deductions not supported by experimental data. This is the statement of the ESC Council of Hypertension. They say that because the social media related amplification, patients taking some drugs for their high blood pressure and their doctors have become increasingly concerned and some cases have stopped taking ACE or ARBs medications. This speculation about the safety of ACE or ARBs treatment in relation to COVID-19 does not have a sound scientific basis for evidence to support it. Indeed, there is evidence from studies in animals suggested that these medications might be rather protective against serious lung complications in patients with COVID-19 infection. But to date, there is no data in humans. The statement of the European Society was very precise and was very sharp in this aspect. The statement of the ACCHA and Heart Failure Society of America was more reluctant, however, but they were sharp in not stopping medications. They said that currently there is no experimental or clinical data demonstrating beneficial or adverse outcomes with background use of ACE ARBs or other RAS antagonists in COVID-19 or among COVID-19 patients with history of cardiovascular disease treated with such agents. The Heart Failure Society of America, ACCHA, recommend continuation of RAS antagonists for these patients who are currently prescribed such agents for indications for which these agents are known to be beneficial, such as heart failure, hypertension, or ischemic heart disease. In the event patients with cardiovascular disease are diagnosed with COVID-19, individualized treatment decisions should be made according to each patient's hemodynamic status and clinical presentation. Therefore, to be advised not to add or remove any RAS-related treatment beyond the actions based on the standard clinical. Finally, thank you, and I hope that I was able to summarize to you the available data till now.